And welcome back to the morning show. We're down here at the offices for Mohave Dental. You've heard me talk a lot about it. We're down here with my dentist, Dr. Mark Collins. Good morning.
Good morning. How you doing, Bruce?
I'm good. Thanks for being here with us this morning.
Oh.
You know, I talk about you so much, and I tell everybody about all the different things that are going on in my mouth and whatnot. And I thought it was time they got to see who's doing all this stuff. Now, you were on the show some time ago, weren't you?
No, you were here.
I was here?
Yes.
With a camera?
With a camera.
We got to knock off the anesthesia or something. I'm not sure what's going on. Wow. So, you know, a lot of things have progressed. I think I've been seeing you for now, what, 10, 15 years?
It's been a while.
It's been a while. And I remember the old days of coming in here, and, you know, one of the first things you wanted to do, as prescribed, was take some x-rays. Right. And I remember sitting in the chair and getting that thing stuffed in my mouth, and then a big old machine, a big pod coming up, and getting put on the cheek, and then taking the film, and it had to go back to a dark room.
Right.
And one of your gals developed it, which was about a 5-minute wait for you.
That's right.
Now that's not the case. This is amazing what's going on right now.
Oh, yeah.
The technology that's involved. And what we're looking at is the technology I was kind of telling you about the other day. They have, well, that's the little camera right behind the doctor here. That one right there. And that goes up to your mouth. They take the picture, and within seconds, it's up here. That's got to help a great deal.
Oh, it's wonderful. Digital radiography is the way to go. It's less radiation, about a quarter of the dosage you used to use.
Oh, really?
Yeah.
And far quicker?
It's far quicker, seconds.
Is it a little better resonance? Is it a better picture than you've had?
Well, the picture is larger, so we can actually see more detail.
Okay.
So I don't know for sure that it's better quality. It's just it's larger. We can see what we could never see in the past.
Well, now, for instance, on this, and this is, I'm going to tell you, this is one of my little jewels up here. But this is up in here, and you can see there's a vacancy right there. This is not long after we pulled the tooth out. But what we had to do to get this implant ready to go was basically, this is, am I right? This is a sinus right here?
Yeah, you can actually draw that too. If you
want. Okay.
We can actually go in there and see, draw. And so if we're looking at this, we look at this little line that you see, that is your sinus, anything above this line.
Okay.
And it traces all the way up like this.
And this in here, this area is all bone.
This is this white area right there, that's all the bone, and this area, of course, is where there used to be a tooth.
Right.
So in your situation, we measure this bone right here to see what the distance of the bone from the sinus is. And with there not being enough bone, we had to go in there, we had to make bone and lift that sinus up so that we have room for the implant or a little screw to go up inside there.
Now, you told me that this sinus, which everybody has,
right,
if they're normal,
you all do,
which is right up, kind of right above the, or gosh, I guess right in between the cheekbone and the tooth line, right?
Yeah, pretty much, yeah.
Pretty much, but there's a indentation in the skull that this rests back inside.
Correct.
But you say this is a membrane similar to what you'd find in an egg.
Exactly. Just like if you took a boiled egg and you pulled that shell off, you got that little thin membrane there. It's about the same diameter as that. In fact, that's how when some dentists are learning to do sinus lifts, they actually play with those membranes and eggs to figure out how to do it.
I'll be darned.
Yeah.
Now, we did do a sinus, the doctor did, I was just laying there as patient, but he did a sinus lift, and what happened is that he was able to bore into the bone right there. I shouldn't be touching the screen probably.
It won't hurt it, yeah. We have to scrub them all the time.
Okay.
So if you want to look at that, we'll pull up a picture of what it looks like afterwards.
There you go. Now you can see that what this is the base of the implant that's going to eventually be up in here. But to get that in there, you can see the sinus had to be pushed up. What I call it, the sinus?
Yes, the sinus.
The sinus had to be pushed up and out of the way.
Yep.
Otherwise, could have punctured it or any number of things,
exactly.
Right?
Whereas it used to be right like this, going up. What we've done is we moved it up approximately 4 millimeters, and you can see a little dome up here where the sinus is actually pushed up right here now. And then there's bone growth that's going on in this area right there.
Because you did put some synthetic bone in there mixed with some of my bone off
that we took out or harvested from you. And what that happens is all the bone that's synthetic that was put in there dissolves over time, and your natural bone will grow. That synthetic works like a ladder, and the bone comes in and grows in between the ladder, and then the ladder dissolves.
Wow. Now, is this common on a lot of people when you do the upper that you've got to move that sinus?
Yeah, if you have the tooth missing for a short time, you know, like a week or two, you don't always have to do a sinus lift. But if somebody's been missing a tooth for more than a year or two, then what happens is that sinus will drift downward and the bone gets shorter and shorter, and then they end up having to have a lift. And one of the ways people feel this is a lot of times they start getting a lot of sinus infections because if that sinus drips down quite low, it becomes a pool for fluids to hold in.
All for crying out loud, really?
Yeah, so people who get their sinus lifted like this, oftentimes their sinuses are actually going to feel better for them.
Wow. So what this is now, once this all heals, and it takes a couple months to heal, once this all heals, we'll be able to go back in with the crown that will go up inside there and tie in, and you will not be able to tell the difference between these teeth and that tooth. That's going to be amazing.
Yeah, well, it's wonderful. You can floss it, everything, just like a normal tooth. You can't tell the difference. The only one who tells is your dentist.
Yeah, exactly. Now, the lower, your jawbone, we've put about 3, I think, down there. All he's going to show you.
See, I don't think I have a photograph, but might have.
Oh, this is amazing. No, that's all this.
Yeah,
oh, there's one.
There's a couple of the implant screws.
Yeah. So I actually had 2 put back to back, and that's in the lower jaw.
Yep.
And
No, that was it. Oh, that was the tooth before we had to take it out.
Oh, okay.
Yeah.
Before it heals up anyway, and then you can just put that stud in there, put the crown up there, glue it in, and I cannot tell the difference. It's impossible to tell the difference for me. It's very nice.
Yeah, if they're placed right, the angle's right, everything's right, it shouldn't be any different than a normal tooth.
You know, one of the things that I've discussed with our viewers many, many times is the simple fact you don't like to rush these things. I mean, there are places up in Las Vegas, same day you can have an implant in. It's dangerous, isn't it?
Well, it is. You know, with the if you wait on it, they have about a 95 to 98% success rate. If you try to do it, put the tooth on the same day, which they'll put a temporary tooth on, your success rate goes down to below 50%.
Wow.
And it's easier for the doctor to put it that way and then hope that you don't show back up for a while.
Yeah.
But it really is not the best benefit for you. And there are some things you have to take and consider. If a person has got a serious uncontrolled diabetes, they can't do implants.
Oh, really?
Their body would reject them.
Oh, for heaven's sake.
But, you know, for the most part, I do like to play it safe. I've done enough research on this, enough literature on that I know what works and what doesn't work. That, you know, that was actually, I did a National Institute of Dental Research Foundation scholarship years and years ago.
Right.
Where I did the longevity of dental implants. You know, so my research is what told the dental all over the world how long implants would last. And so I know very well the shortcuts don't work.
They just don't work well.
Exactly.
You know, what brought me to the doctor here is years and years and years and years ago, the first time I had a temporary crown put on. I can't remember. Oh, they did a root canal and didn't bother leaving it open to where it could drain. And I had to call him up, and he came down on a Saturday, if I remember right, Friday or Saturday night, and because I was ready to shoot myself. It hurt so cotton picking bad, and we've been coming to him ever since. In fact, just minutes after we walked in here, he just finished with my wife on this, and we got her crown replaced on it. Well, if you have any questions, honestly, I want to come down here again and do this on another subject, if you don't mind.
No problem.
But I just wanted people to meet you. If you've got any questions, you can give them a call. The phone number's on your screen, and I really suggest that you come down and see Dr. Mark Collins. Thank you so much.
Thank you, Bruce.
Good seeing you. There you go, ladies and gentlemen. Fort Mohave Dental. Use it, I do.